Today I will discuss about diabetic ketoacidosis in children. According to BSPED guideline, uh, there are some biochemical criteria. These are blood glucose level more than 11 millimole per liter, blood ketones more than 3 millimole per liter, or urinary ketone bodies are 2 plus on dipstick test, or acidosis pH less than 7.3 or bicarbonate level less than 15. And clinically, triad includes signs of dehydration or shock, acidotic breathing, altered consciousness. According to your pH level and bicarbonate level, DKA is classified into three types: mild DKA, moderate DKA, and severe DKA. When your pH is 7.2 to 7.29 and bicarbonate less than 15, it is mild DKA. pH 7.1 to 7.19 and bicarbonate less than 10, it is moderate DKA, and when pH less than 7.1 and bicarbonate less than 5, it is severe DKA. And it is assumed that in mild DKA there is 5% dehydration, in moderate DKA there is 7% dehydration, and in severe DKA there is 10% dehydration. So these are the common clinical features in DKA in children. Vomiting without diarrhea. Patient will be dehydrated, but urine output will be good. Patient may present with abdominal pain, severe respiratory distress, but without any lung signs. Patient may be comatose and altered consciousness level. So how will you diagnose this patient? Okay, so our random blood sugar, urine for sugar, blood ketone body, urinary ketone body, arterial blood gas analysis, or urinary ketone body or dipstick test, and septic screening includes complete blood count, chest X-ray, blood culture, urine culture. And for monitoring purpose, random blood sugar, serum electrolyte, calcium, magnesium, renal function test, ABG, and ECG. So how will you manage this patient? Okay, so this is a emergency in pediatrics. So first, ABC resuscitation, give 100% oxygen. Then you should be give initial bolus, and choice of fluid is normal saline. So if the patient is in shock, at first 20 ml per kg normal saline over 15 minutes, then reassess the child, give another 10 ml per kg and total up to 40 ml per kg. Then consider inotrop if needed. Okay, so remember that this fluid should not be subtracted from the total fluid. Well, if the child is in no shock, then give only 10 ml per kg normal saline over 60 minutes, and you should be subtracted this bolus from your total fluid. So next is your fluid management requirement. Total requirement will be deficit plus maintenance. So how will you calculate your deficit? So previously we told that in mild DKA 5% dehydration, moderate 7% dehydration, and severe DKA 10% dehydration. And you have to calculate this deficit, and this deficit fluid should be replaced over next 48 hours along with maintenance fluid. And how will you calculate maintenance fluids? It is by Holiday-Shaker formula. That means if your child is 20 kg, for first 10 kg it is 100 ml per kg fluid, and next 10 kg 50 ml per kg fluid, and the rest for 20 ml per kg fluid. Okay, so there is an example: a 6-year-old boy weighing 20 kg, pH 7.15, that means moderate DKA, and no shock. Okay, so how will you manage the child? As there is no shock, at first you have to give 10 ml per kg normal saline, that means 20 ml normal saline over 60 minutes. Okay, so then calculate your deficit. Moderate DKA, that means 7% dehydration, so 20 into 7% equal to 1400 ml, and subtract the bolus 200 ml, that is 1200 ml, and you have to give this fluid over 48 hours, that means 25 ml per hour. Now maintenance fluid 1500 ml, that means 62 ml per hour. So total fluid is 25 plus 62 equal to 87 ml per hour. So type of fluid is normal saline until random blood sugar is less than 14 millimole per liter. Okay, so here is an important point that you have to give potassium supplement. Add potassium 20 millimole in 500 ml normal saline. If potassium is less than 3, consider reduce insulin. So okay, next is insulin infusion. Start IV insulin infusion after 1 to 2 hours of IV fluid therapy. So this is very important. You have to give fluid therapy first. You have to correct your shock. Then you start your insulin infusion. So the dose of insulin is 0.05 unit per kg per hour and 0.1 unit per kg per hour. Both are accurate, but most preferable dose is 0.05 unit per kg per hour unless adolescent or severe decay. Okay, so there is a shortcut procedure. Add 50 unit soluble insulin plus 49.5 ml normal saline. So that means 1 ml normal saline equal to 1 unit insulin. So the trick is 0.05 unit per kg per hour equal to 0.05 ml per kg per hour. So our child is 20 kg. We will give 0.05 unit per kg per hour. So that is 1 ml per hour. Okay. Okay. So so there is acidosis. Will you consider bicarbonate therapy? No, bicarbonate is usually contraindicated, only indicated on severe hyperkalemia, severe acidosis with impaired myocardial contractility. If acidosis is not correcting or there is no improvement over 4 to 6 hours, then you check for sepsis. Again, check your insulin dose, hyperchloremic acidosis, inadequate resuscitation fluid. Calculate your anion gap. It is 20 to 30 in DKA. If more than 35, consider sepsis. Okay. So when your glucose level is less than 200 milligram per dl or 14 millimole per liter, change your fluid from normal saline to 5% dextrose with normal saline and plus add potassium. If blood glucose is less than 6 millimole per liter, decrease glucose concentration. If less than 4 millimole per liter, give 10% DA 2 ml per kg. Once your ketone level is less than 1 millimole per liter, switch from IV insulin to subcutaneous insulin. Continue insulin infusion while glucose is infused, as insulin is required to switch off ketone production. So when can you suspect that your DKA is resolved? When pH more than 7.3, bicarbonate more than 15, blood ketone more than 1 and blood glucose less than 14 millimole per liter. Stop IV fluid when ketosis resolved and oral fluids tolerated. Stop IV insulin infusion at least 30 minutes after starting subcutaneous insulin. Okay, so this is very important. You have to start your subcutaneous insulin first, then after 30 minutes you can stop your insulin infusion. Okay, so there are many complications in decay. The most important and dangerous complication is cerebral edema. So how will you recognize cerebral edema? Patient may have a headache, patient may be agitated, unexpected bradycardia, increased blood pressure, deterioration of consciousness level, abnormal breathing, abnormal posturing, pupillary inequality or dilatation. Okay, so treatment of cerebral edema is 3% sodium chloride 2.5 to 5 ml per kg over 10 to 15 minutes, or mannitol 20%, 2.5 to 5 ml per kg over 10 to 15 minutes. You can give one of them. Both are have equal activity, and fluid restriction to half maintenance rate. If there is no improvement in mannitol infusion within 30 minutes, then give 3% sodium chloride or second dose of mannitol. If patient is stable, then do a CT scan to exclude any thrombosis, hemorrhage, or infarction. And other complications include hypoglycemia, infection, hypokalemia. And how will you monitor the patient? Hourly capillary glucose level and ketone levels, arterial blood gas analysis, electrolytes after 2 hours, then 4 hourly, and 4 hourly clinical status, vitals, neurological status, including your fluid balance record and ECG tracing. So that's all. Thank you.